So these HLA types, 301 and 401, are most commonly associated with the development of autoimmune hepatitis. And another thing, we sometimes think there are antibodies in the serum and plasma cells are in the biopsy, so mostly it's a antibody-dependent response. But all the weapons of immunity are working in tandem here. The cytotoxic T cells, the NK cells, all are attacking together the hepatocyte. And calling of molecular mimicry, what all? Viruses, vaccines, and drugs. Very common drugs we regularly take, like statins, diclofenac, cornidazole, we can see in the list of drugs which are commonly associated with autoimmune hepatitis. Now, classification is based on the type of autoantibody the patient has in his or her blood. ANA and SMA are most commonly found if it is in the type 1. It is the most common subtype. While in the pediatric population, LKM1 and LC are commonly seen. And the third type, a little controversial, presently described, has soluble liver pancreas antigen, and its increased risk of relapse is there according to this type. These are all the several autoantibodies which can be found in the blood and helpful in diagnosis. Now, why biopsy? I told I will be a little more, I talk more on histopathology. So why biopsy? We know biopsy is an invasive procedure. And with advent of imaging, serology, biochemistry, liver biopsy for medical causes has become a rare cause nowadays. So biopsy is still essential for this disease because it has a heterogeneous presentation with much subclinical cases. Actually, 1/3 of the patients present with cirrhosis at presentation. And actually, there is lack of any sensitive laboratory marker. And so if we found this international guidelines, almost all European, American, all guidelines suggest histopathology or liver biopsy to be done for diagnosis of autoimmune hepatitis. Now, several scoring system was developed for diagnosis of autoimmune hepatitis, mainly for research initially, but now used routinely in clinical practice. The most simple of them is the simplified criteria, which is accepted by the International Autoimmune Hepatitis Group. And here we can see liver histology is there. And where there are 2 points, if it's compatible, it will get 1 point, and typical, it will 2 point. And if the total sum of the score is equal to more than 6, it's probable as AIH, and more than 7 will be definite AIH. So let us see what is typical and what is compatible. 3 features: lymphoplasmacytic interface hepatitis, hepatocytic rosettes, and emperipolysis. If these 3 are found in the liver biopsy, we take it as typical of AIH. While if any one of them is absent, it is taken as compatible, and presence of another liver disease makes it atypical for AIH. So, though there are no pathognomic signs in liver biopsy for AIH, these are 3 as the main features which are found. So if you see in a liver biopsy, this is the typical feature, mainly interface activity with zone 1 lobular hepatitis. Initially, zone 3 is not so much affected, but later on it may be affected. So what is lymphoplasmacytic interface hepatitis? Interface hepatitis is when the inflammation spills over from the portal tract to the lobule, infiltrating and injuring the limiting plate hepatocytes. It is a factor which determines the activity of the liver disease. And in fact, chronic hepatitis term is a clinical term. So for we pathologists, interface hepatitis helps us to understood this patient is going a chronic active procedure. And in the biopsy, we will see typically this is the portal tract, this is the lobule, and here this is the spill of inflammatory cells infiltrating the hepatocytes in this, the limiting plate. This is a higher power view. We can see very beautiful plasma cells and lymphocytes which are infiltrating in the lobule from the portal triad. And lymphoplasmacytic infiltrate is our requirement for autoimmune hepatitis. So plasma cells should be there, and if a collection of more than 5 plasma cells are there, it is taken as a plasma cell cluster. Emperopolis, we all know, thanks to Rosai-Dorfman syndrome, but for here, it's a little different. Not like reticuloendothelial cells, here hepatocytes, which is epithelial, has undergone emperopolis, and it is a typical feature of autoimmune hepatitis. Here also we can see, so in liver biopsy we have to hunt for these things because lymphocytes in sinusoids often confuse with emperopolis. Rosette. Rosette is a regeneration feature of disease, and if there is a clear space where around hepatocytes are arranged, actually the stem cell, when they regenerate to proliferate new hepatocyte, they sometimes take the biliary morphology and gives this rosette-like appearance. So what other biopsy features which we find are portal triaditis, that is portal lymphoplasmacytic infiltrate, lobular inflammation, lobular plasma cells and lymphocytes, and a little rare, but in India we get a lot of them, bile duct injury. Though bile duct injury is usually taken as a feature of primary biliary cirrhosis, we can find them in some cases of autoimmune hepatitis. And if bile duct injury is there, a typical feature can be seen, that is cholestasis in liver biopsy. So what were the limitations of this scoring system and criteria which I told of till now? So acute flare of AIH is not represented, and this plasma cell rosette emperopolis has been found in other liver disease also. And differentiation from primary biliary cholangitis or cirrhosis is difficult. So different approaches are being tried now to address these problems. Firstly, divide autoimmune hepatitis in two varieties, chronic and acute. Chronic, as I told, has a more portal disease, portal lymphoplasmacytic infiltrate with interface hepatitis, while acute presents a typical lobular inflammation and lobular necrosis. So this is a case of acute autoimmune hepatitis. We can see almost there's a bridging necrosis in the liver, and these are the portal triads which are relatively spared. This is again one of our cases showing panacyclin necrosis. Some of the hepatocytes here are spared. And collagen stain is helpful in this condition sometimes because the collagen takes a dark blue color while the necrosed area is much lighter blue, which helps us to differentiate between fibrosis and necrosis in the liver. And of course, reticulin stain is also helpful where the collapse of reticulin network of liver is seen. So newer proposed scoring systems have been developed. This is one from US, from Balitzer et al. It mainly differentiates from PBC. And they have given a score of 0 if there is a florid duct reaction, bile duct loss, and CK7 positivity. And if histology and mild inflammation is present in the lobule with mild necrosis, then it's histology 1. And if moderate or severe is present, histology score is next. And the newer system is the European Society Pathology Criteria, which develops the category as likely for AIH, possible for AIH, and unlikely AIH. And divided again into two types, portal hepatitis and lobular hepatitis, where predominantly lymphoplasmacytic infiltrate is present and only lobule. In addition, one of these two must be present to call is at likely for AIH. And if they are absent, these two are absent, it is possible for AIH. And if, again, we are getting some other liver disease, it's unlikely for AIH. This is being reviewed by the International Autoimmune Hepatitis Group for acceptance. These pictures show the pictorial representation, with, either interface hepatitis or lobular infiltration, or both should be present for possible or likely. And if they are absent, most probably they are unlikely. So grading is very important, and various grading system can be used. Usually we use ISHAC system, which is the modified histological activity system, where we grade according to interface hepatitis, confluent necrosis. In every category has given a score, and then focal necrosis and portal inflammation. And the total score is added to be 18. And more than 6 is definitely active hepatitis, and more than this A more than 2, B more than 1, and C more than 3 is taken as mild, more than mild inflammation. Staging is important. Staging is important as it determines the prognosis hugely, and for this we need connective collagen stain like mesenteric or von Giesen, whatever anyone does. So first we have the fibrous expansion, then periportal fibrosis, and then bridging fibrosis. And lastly, the end stage is stage 4, which is cirrhosis of liver. We can see bridging fibrosis in this. This is called, blue is collagen, and this color is the lobule. And here we can see nodule formation with bridging fibrosis. It's a cirrhosis. So when we will call a patient in remission, usually clinicians follow ALT and absence of hyperglobulinemia to tell patient is in a remission. But studies have been shown that though the patient is in serological remission, they are not in histological remission, especially in cirrhotic patients. So nowadays, sometimes paired biopsy is done, though mostly in research settings, not routinely. And if a ISHAC's grade in the repeat biopsy is less than 4 with mild portal inflammation, we can take as the patient in histological remission. Again, for relapse, presence of interface hepatitis and presence of plasma cells are taken as the patient is going to relapse in autoimmune hepatitis. So what is the difficulty areas in autoimmune hepatitis diagnosis? Firstly, there are cases of antibody negative patients. Around 10 to 20% patients are autoantibody negative. So their serology will be negative. Still, they will be having a disease, and they progress very fast. So biopsy is essential for them. Second category, AMA positive AIH. AMA, we know it's diagnostic marker for PBC. So we confuse for PBC or the overlap syndrome, but we have to be careful and remember about this. Viral hepatitis with autoantibodies are also a category, and drug-induced liver injury is always confusing. Lastly, overlap syndromes. These are the diagnostic criteria where both AIH and PBC are present. Both biopsy and clinical features has to be present. Florid ductal reaction is typically seen in these cases, along with presence of CK7 positive hepatocytes at the periphery are very helpful. And if you do copper stain, rubionic acid stain, presence of copper also helps in the diagnosis. So to conclude, any liver biopsy also in liver autoimmune hepatitis, clinicopathological correlation is very important. So very often we have to dial our hepatologist or gastroenterologist friends and discuss the cases, especially to rule out an overlap condition and differentiate from drug-induced liver injury. Staging grading is important for prognostication, And early diagnosis is important to prevent advanced stage of disease where liver transplant becomes inevitable. Thank you.
Thank you, Ranajoy, for that wonderful talk. Since we haven't been putting questions to the speakers because of lack of time, thank you very much. And I, on behalf of the organizers, would like to request you to accept a small token of our third talk in this session is a talk by one of the supporting partners from Lupin, who is going to speak on endocrine abnormalities in patients with immunotherapy. Yes, the speaker is Dr. Silima Tarenya. Silima is here? Oh, yes. Silima is an endocrinologist. She did her DM endocrinology from NRS Medical College. She is a consultant with us as an endocrinologist, and I know her very well and their family. So, Silima, please.
Thank you, sir, for the kind introduction. So it's indeed a great privilege. At the very outset, I would like to thank the organizing committee of CAPCON and the supporting partner Lupin for this opportunity. And it's also a delight to see Deepak Mishra, sir, as the chairperson here. So I have been entrusted to speak on endocrine abnormalities in patients with immunotherapy. So immune checkpoint inhibitors in the last few years, they have emerged as very powerful tools in the management of cancer. And they basically block the immune checkpoints, thereby unleashing the T cells and targeting attack to the cancer cells. I would not be going in details because our pathology colleagues and seniors would be having a greater understanding in better depth on the pathogenesis. So I'll be sticking to the endocrine abnormalities. So mostly they are the PD-1, PD-L1 and CTLA-4 inhibitors that are responsible for causing the endocrine abnormalities. To start with, thyroid dysfunction. Thyroid dysfunction is the most common endocrine abnormality associated with immune checkpoint inhibitors. It ranges from a spectrum of subclinical hypothyroidism towards overt hyperthyroidism at one end. Amongst the entire spectrum, hypothyroidism is the most common one that we encounter. Many a times, this hypothyroidism is preceded by a period of transient thyrotoxicosis, which is mild and doesn't usually require any treatment. So it can be either transient or permanent. Anti-TPO positivity is found in about 20 to 40% of the cases. Though Graves' disease is very, very rare, with tau, 1 or 2 cases have been reported in literature. Coming to signs and symptoms, both ICPI-related thyrotoxicosis and hypothyroidism have mild and non-specific symptoms. For instance, for thyrotoxicosis, we have tremulousness, tremors, palpitations, increase in defecation, anxiety, and rarely, very, very rarely, thyroid storm. Coming to features of hypothyroidism, it is even more non-specific. Patients would be complaining of dry skin, constipation, weight gain, fatigue, etc. But the good part is, both these conditions are manageable and many a times they are reversible also. So how do we manage? We prescribe for a thyroid function test. That is, most commonly we start with a free T4 and a TSH. So for hypothyroid, it would be a low free T4 in the background of a raised TSH. And for hyperthyroid, it would be increased FT4, total T3 and a suppressed TSH. Many times we encounter subclinical hypothyroidism. That is, we get referrals where the TSH is slightly raised, maybe on the higher side, say 8 or 9, and the free T4 is normal. So in this background, we keep the patient under a close follow-up, or if the patient is having an associated goiter or the TPO antibodies are positive or there are some symptoms, we might as well start with a low-dose levothyroxine treatment. For hyperthyroidism, antithyroid drugs are rarely required because, just like I mentioned, these are usually destructive thyroiditis and they usually end up resolving and restoring the patient to a euthyroid state or to a state of permanent hypothyroidism. Beta blockers are required in symptomatic patients to tide over the thyrotoxic phase. So what about the immune checkpoint inhibitors? As far as thyroid dysfunction is concerned, therapy should not be stopped. Only if there is a severe thyrotoxic phase, it can be interrupted till we tide over the crisis. Coming to the next one, that is diabetes. So immune checkpoint inhibitor related diabetes is very, very rare. There are probably 40 to 50 cases reported in literature. But when present, it is potentially life-threatening, and it is in most of the cases autoimmune mediated. So what are the characteristics of diabetes in a background of ICPI inhibitors? That is, the onset of hyperglycemia is very, very rapid. Now, when I'm saying by onset, the duration from the initiation of the ICPI to the development of diabetes can be between 1 week to about a year. But the moment it starts developing, the glycemic surges peak very, very rapidly. So first, very, very rapid progression of hyperglycemia. Second, swift progression to endogenous insulin deficiency. So basically, this is going to mimic type 1 diabetes. When we classify diabetes unrelated to malignancy, for the matter, we discuss type 1, type 2, LADA, MODI, pancreatic diabetes, and for the matter. So this has a very strong resemblance with type 1 diabetes, and also because there is severe endogenous insulin deficiency, there is high risk of running into diabetic ketoacidosis, which is a fatal condition. So basically, there is a subset of type 1 diabetes known as fulminant diabetes, which was initially discovered in Japan. That and ICPI related diabetes are very, very similar because both of them have absolute destruction of beta cell of pancreas, very, very rapid development of diabetes, absolute insulin requirements, and development of decay. The only difference is in the fulminant type of diabetes, we do not get that many antibodies, whereas in case of ICPI related diabetes, antibody is present in about 50% of the cases. It can be GAD65, IA2, etc. Now coming to the diagnosis, so HbA1c. So we all know that HbA1c gives us an idea about the past 3 to 4 months glycemic status, but in this background, HbA1c might not be able to help us as much because the progression of diabetes is very, very rapid. So for instance, we might get a patient with very high levels of glucose, blood glucose, but a HbA1c which is either normal or just mildly high. So that is the caveat. C-peptide levels would be low. Pancreatic imaging might not be contributory. We might get some amount of inflammation or we might not get anything suggestive also. Autoantibody is positive in about 50% of the cases. How do we manage? Counseling is very, very important, not only to the patient but also to the relatives for the development of diabetes as well as to take precautions against decay. If the patient develops decay, then electrolyte balance, dehydration correction, as well as insulin, everything needs to be given on time. What about corticosteroids? So steroids, basically, few studies and trials have shown that they do not really help much in this kind of a diabetes. Rather, they worsen the situation because we know that steroids cause a very big increase in the glucose levels. So we do not suggest administration of steroids. Coming to the next organ, hypophysitis. So hypophysitis refers to inflammation of the pituitary gland. Now it can be either primary or secondary depending upon the etiology. If the pituitary gland is only involved, that is the inflammation is restricted only to the pituitary gland, it's primary. If it is in association with systemic diseases like sarcoidosis, vaginous granulomatosis, infections like tuberculosis, fungus or any other drugs, and that is secondary. It can also be classified as lymphocytic, granulomatous, xanthomatous, plasmacytic depending upon the histopathology. Now coming to the incidence of hypophysitis, it has been seen that it occurs more when a combination therapy is used in comparison to a single agent. And amongst the single agent, the CTLA-4 inhibitor ipilimumab is notorious for causing the same. Another point to be noted is that The ipilimumab-mediated hypophysitis or the immune checkpoint inhibitor-mediated hypophysitis is more common in men, which is in contrast to the usual common lymphocytic hypophysitis that is found in women during their pregnancy towards the end or during the postpartum period. And a hypothesis has been postulated that since ipilimumab is one of the most common agents and that is used in men, melanoma, and melanoma more commonly occurs in men, so probably that might give us some explanation for this. And both the ADCC and complement pathways are involved in this. This I wouldn't be going in details. Coming to the symptoms. So the symptoms of hypophysitis again can be non-specific like headache, fatigue, nausea, any kind of weakness. For instance, males, they might develop some kind of loss of libido, erectile dysfunction, hot flushes in women, etc. They occur usually weeks to months of the ICPI therapy. One thing to remember is that in contrast to other pituitary masses where we develop mass effects because the pituitary lesion is larger and that goes and impinges on the optic chiasma leading to visual impairment. But in this case, in a background of hypophysitis due to immune checkpoint inhibitors, the size of the pituitary is not that large. So it's either mild or maybe slightly enlarged, so we do not really get any mass effect. Now, what are the features? Central hypothyroidism and central adrenal insufficiency. These are two features which are very, very clinically relevant because if we miss a central adrenal insufficiency, then the patient would land up in a very bad state, and due to glucocorticoid deficiency, he or she might land up in crisis, and that would be a life-threatening situation. So we really need to pick up central hypothyroidism and central adrenal insufficiency. So how do we pick up central hypothyroidism? Low free T4 levels in a background of inappropriately normal TSH or low TSH. Because in primary hypothyroid, we get low free T4 levels, TSH is high. But in secondary hypothyroid, low free T4 and a normal TSH. That is where a suspicion should come in. Coming to central adrenal insufficiency. So here the cortisol level would be low and the ACTH would be inappropriately normal. This situation may be life-threatening. Another way to look for cortisol insufficiency is to go through a synactin stimulation test. That is 250 microgram of synthetic ACTH we're going to administer, and 60 and 30 minutes later we check for the cortisol. If the levels do not cross 18 microgram per DL, it means that the patient is insufficient. But there are few issues with this test. If a patient is diagnosed with an early central adrenal insufficiency, it might so be that the adrenal receptors are still not extinguished, they're still not atrophied, so it might falsely respond. So we do have to deal with these challenges. Another symptom is hypogonadotrophic hypogonadism, because in the pituitary we have all these cells. The adrenals and hypothyroid we have already discussed. The gonadal cells may be affected. And lastly, coming to growth hormone, prolactin and ADH, we don't really have much studies on growth hormone. Prolactin levels are usually on the lower side, and ADH is also mostly unaffected in hypophysitis. How do we diagnose? For the diagnosis, it is not just the clinical parameters. We also need to look at the radiology as well as the biochemistry. Like I mentioned, you have pituitary enlargement. We can see here that there is a homogeneously enhancing pituitary gland in the first picture itself. So that suggests hypophysitis, and we can go for serial MRIs to compare. Stalk thickening is possible, but we do not have chiasmal impingement. Another point is that there is temporal dissociation between radiographic enlargement and biochemical perturbation. So it might so happen that the patient has developed an enlarged pituitary, but all the biochemical reports are normal, and once the pituitary starts getting back to normal, the reports are getting altered. So while treatment, that is also very important. How do we replace? We start with levothyroxine at low doses. Our usual dose is 1.6 microgram per kg. But in a background of hypophysitis due to ICPI, the rationale behind starting a low doses, firstly, these patients might be on the elder side. There might be some comorbidities like cardiovascular disease, for which a high dose of levothyroxine might precipitate an ischemic attack. Secondly, many cases, this hypothyroidism is very transient. So there is a strong possibility it might revert back. Last but not least, if we start low, we can always go higher. Monitoring is very important. Central hypo is always to be monitored with free T4 levels and not TSH levels. Coming to glucocorticoids, if there is an adrenal crisis, then we need to administer IV hydrocortisone, IV glucocorticoids, but if the patient is just having symptoms but is not in crisis, we can go for oral dose glucocorticoids, hydrocortisone 10 mg in the morning and 5 mg at 4 p.m. Very important is to look for the HPE axis recovery, after which we might as well decide to taper off steroids or not, but in very, very rare cases, the adrenal axis recovers. So this patient might need lifelong replacement of hydrocortisone. Like I just mentioned, recovery from central AI is rare. Recovery from central hypothyroidism and hypogonadism is common. Adrenal, we were discussing about secondary adrenal insufficiency, now coming to primary adrenal insufficiency. Here the cortisol levels are low and the ACTH levels are very, very high. Another difference with secondary adrenal insufficiency is that both the mineralocorticoid and glucocorticoid axis is affected, that is zona glomerulosa, zona fasciculata. So both are affected. While treatment, we not only need to replace with glucocorticoids, mineralocorticoids also need to be replaced. And though it is very, very rare, few cases where they have shown that adrenals have been involved due to the immune complex inhibitors, it has been shown either there were METs or maybe there was some kind of a hemorrhage or destruction of the adrenals. Management is replacement of both glucocorticoids and mineralocorticoids. Last but not least, parathyroid. Hypoparathyroidism is a very rare event and management would be just like we manage cases of acute hypocalcemia, either with IV calcium and once patient is stable with orals. This is my last slide. So we were just discussing the endocrine organs being affected. Now we'll talk of something else, that is the glucocorticoids that is rampantly used in a background of malignancy and usage is inevitable. High dose glucocorticoid also have numerous side effects. The special mention would be hyperglycemia and osteoporosis. Osteoporosis, we need to run a DEXA scan and then treat it accordingly. Hyperglycemia has to be managed with insulin predominantly. And risk of adrenal suppression. So whenever an exogenous steroid is administered, it bears a risk of suppressing the adrenals for a long period of time. So we need to give the physiological dose of steroids as well as routinely test for the recovery of adrenals. Thank you so much for your patient hearing.
Thank you, Silima, for that lucid talk. It was very crisp. And I'm sure being a clinician, she has reached the audience. So since unfortunately we don't have adequate time, we'll not have any questions. But thank you very much. And from the organizer's side, I would like to request you to accept. We come to the last talk of this session, and the last talk will be delivered by none other than Dr. Shilpa Bhartia. She needs no introduction, at least to me. She is a very astute hematologist in this city and now has a hospital of her own. And she is going to speak on a very, very important topic that is also very dear to me, autoimmune hemolytic anemia. So without wasting time, Shilpa, who had her hematology training from the UK, and after that she's here for last almost a decade. Thank you. Please.
Thank you very much, sir, and thank you, Capcom, for letting me talk on autoimmune hemolytic anemia. So as a hematologist, I think without pathologists, we are nothing, and we are kindly part pathologists. So anything we do has to have a clinico-pathological correlation, and autoimmune hemolytic anemia is a classic example of this. So basically, I think all of you know this, but just, going through the process, it is a decompensated, acquired hemolysis, which is caused by the host immune system acting against its own red cells, like any other autoimmune disorder. It is not very uncommon, 1 in a million, but we have significantly seen the increase after COVID, either directly due to COVID infection or the vaccine-induced autoimmune complications. It can be primary, idiopathic, where there is no underlying cause, or it can be secondary due to the underlying promoting immune dysregulation. And when we classify them serologically, which is very important, it is either the warm type, the cold type, the PCH, or the mixed autoimmune hemolytic anemia. And today the talk is basically going to talk more on why we need to classify it and how we use our various laboratory tests to identify the anemia. So primarily they will present to the physician with anemia, which is non-specific, present with symptoms of weakness, dizziness, dyspnea. They will have features of hemolysis, which we need to suspect. So they will have jaundice, or they may present with a history of dark urine if it is an intravascular hemolysis. They may have a symptoms of underlying secondary autoimmune disorders such as SLE. And sometimes severe hemolysis on examination can cause hepatosplenomegaly, hemoglobinuria, and signs of heart failure. The very much more rarer type is a cold agglutinin disease, where you see a cold-induced acrocyanosis, where they get dusky blue fingers. They can have a dusky blue nose tip or ears, and this occurs in about 40 to 90% of the patient who have got a typical CHAD with an underlying SLE. PCH, the paroxysmal cold hemoglobinuria, is rather rare, more common in children, and presents 1 to 2 weeks after an upper respiratory tract infection with acute fever, leg pain, back pain, and hemoglobinuria. This fortunately settles spontaneously. So when we look at the diagnostic approach, what are the typical lab parameters? So we can't do the extended panel right at the start, right? So we do a basic hemolytic screen. And this will include our bilirubin, both conjugated BUBC, what we call, the reticulocyte count, which will be increased. The LDH can be significantly high. The serum haptoglobulin will be reduced. And the blood film, which is very important, will show us spherocytes, NRBC. It may show polychromasia and agglutination. So that's when we have to start suspecting, whether it's going to be the warm type or the cold type. And, in fact, we look for guidance from the pathologist looking at the slide to point out to the clinician to request the appropriate tests. Urine dipstick not done, it's done routinely, but it will test positive for blood, but the urine microscopy will not show red cells. If it is intravascular, you can see hemoglobinuria, and for hemosiderin to develop, it may take approximately 1 week. So once we have this sort of picture, clinically we are suspecting a hemolytic anemia and your hemolytic screen is positive, then you have to go and further classify it and question ourselves, is this an immune hemolytic anemia? So what do we do for that? We do the direct Coombs test, direct antiglobulin test, which is the first line test. So the first what you have to do is a polyspecific, where they will look whether the antibodies are of the IgG and anti-C3d type. So this is the initial screening, and this will help us determine the type of autoimmune hemolytic anemia. Once we see it is the IgG type or the C3, we then go on to do the extended or the monospecific Coombs test, in which the diagnostic antibodies, which is either specific for IgG, IgM, IgA, or the complement, we need to decide to classify it as a warm or a cold or a mixed autoimmune hemolytic anemia. So we need to know that just having a positive DAD test is not enough. There may be other reasons other than autoimmune hemolytic anemia which cause a positive Coombs test, which may include infection, liver disease, malignancies, SLE, renal disorders, and if they have received IVIG or anti-thymocyte globulin. So what are we going to do next? Let us accept that not all labs are doing extended workup on hemolytic anemia. These are restricted to bigger hospitals having extensive blood banks. So the spectrum of tests, which will depend on the resources and the methods, the lab where testing is performed. But I want to insist we do not stop just because my lab is not doing extended Coombs tests. I will not start the treatment based on a direct Coombs test. There are several centers where you can outsource the samples and get a complete diagnostic workup. So we need to know what type of hemolytic anemia it is. We have to detect incompatibly during pre-transfusion testing. So you have to inform the blood bank involved that you are suspecting a hemolytic anemia. If there is incompatibility during testing, they have to go on and do elution, adsorption studies. it's also important to get a titer of the antibodies you have, especially cold antibody titration and the autoantibody characterization. So all these things take a long time, and transfusion often cannot be rushed or hushed up because you have to give them time to do all the diagnosis. Otherwise, the transfusion that you do is going to cause more harm than good. So it is very important that selection of RBC is based on urgency. Very rarely you cannot cut short. There is no cut short method. You have to go through the entire protocol before transfusing. So just going back a little bit to the history, how this Coombs test came into place, we know that Second World War, there was a huge mortality and lots of casualties. And I think the Red Cross has recorded about 13 million units of blood was either collected or used during the transfusion to the soldiers. And what they saw, that was, I think, the first time that they were using red cells and plasma and understanding why people are reacting to certain blood groups and antibodies. Just few years before that, Reyes and Sanger, they had worked on the genetics of blood group. And we know these two gentlemen, Mr. Carr, Landsteiner and Alexander Weiner, who were instrumental in developing and defining the ABO types and the RH blood groups. So I think it was during the RH blood group, they saw that the normal form of D, which was the anti-D, is against the rhesus blood group. And there existed a variant known as the incomplete antibody. This could first be detected, what they called that time as the blocking test. And this blocking of RH positive cells, which had been suspended in the incomplete serum so that they became inagglutinable by the normal antibody. So this was just sort of the basic science research that went on to find out further. So following few years, Robin Coombs, he was the one who is, the founder of the Coombs test, in which